So it's my pleasure to be here with you today. Linda, thank you for the introduction. What I'd like to do is talk about what is payment reform and why does it matter to you. I want to give you some sense of what are the payment reform options and also give you some sense of how payment reform is being implemented both in Minnesota but also across the country. And I'm going to emphasize where there's been leadership by employer purchasers elsewhere. Because the point I want to make is employers, when they act, make a real difference in the healthcare marketplace. And then finally, I want to share with you, so what evidence is there for any of these payment innovations? Let's start first with why. My entire career, I've been looking at graphs like this. I don't know about any of you, but the graphs have always looked this way. In 1990, I was an employee benefits manager at Digital Equipment Corporation. We had 120,000 employees, 60,000 in the US, and my job was to manage our healthcare benefits and our costs. We were paying, if we were averaged that year for the United States, $2,900 per capita. We thought that was outrageously high and couldn't believe how much it had grown from what things looked like 10 years earlier. So we're at over 8,000 now. I would dare guess there is no expense in any of your businesses that have grown like this over this time period. I mean, who would allow it to? But this is what's happened for healthcare. The projections for the future don't look much better. So this is a report done by the Minnesota Department of Health for Minnesota healthcare spending. And they are projecting a doubling of healthcare spending in Minnesota over the next decade. So in this particular case, the past is apparently going to predict the future, absent any action. The difference when we compare the cost of the growth in employee wages and in general inflation to healthcare spending, my entire career, it's been a multiplier of 2, 3, 4, 5, 6 times. This shows us that by 2010, the collective growth from 1999 to 2010, or was for 2010, was a 5-fold difference between the rate of inflation and the workers' contribution to premiums. 5-fold difference. What makes this even worse is it's not clear that we're getting any better value. Some people will say, well, of course, spending is a lot more in the United States, but we have a much better healthcare system. You know, the evidence doesn't show that. According to a World Health Organization assessment, and there are many analyses that are done comparing the United States healthcare system performance to other countries, we are just barely staying ahead of Slovenia in terms of health system performance. And we are spending way more than Slovenia, I can promise you that. So while we might feel a little bit better if we said, well, for all of this outrageous growth in spending, we're getting quality that is so much better, the evidence isn't there. There's evidence that for some specific services, we're better than other countries. For example, for certain types of cancer treatment, it appears that the United States actually is better. But overall, no. You don't get better health care in the United States than you get in other countries. The problems, I want to give you 2 examples here. The first is in 2000, the Institute of Medicine published a report titled is Human, Building a Safer Healthcare System. And they estimated at that time that errors that were occurring in inpatient treatment in hospitals, just in that setting alone, caused enough deaths to equate to a 747 crash every single day in this country. Within Minnesota, and I'll note, quality of care in Minnesota is better than it is in most other states. But still within Minnesota, there are big opportunities for improvement. So Minnesota Community Measurement does a fantastic job of reporting on quality of healthcare in Minnesota. And looking at their most recently published healthcare quality report, we can see that patients diagnosed with depression, only 9% have substantial improvement within 6 months. And looking at optimal care for asthma, 24% of Minnesotan children get optimal care, 37% of adults with diabetes get optimal care, and 40% of adults with cardiovascular disease get optimal care. Now, that might be better than in Alabama and Mississippi, probably is, but that's pretty far short of, I think, what you would all want for your employees' independence. So why do we have the problems of both cost and quality? The reasons, of course, are complex. And this fishbone diagram tries to group things into two categories. There are two reasons why costs in particular are growing. One is because the volume of service delivery is growing, and the second reason is because prices are growing. If you look back over, say, 20 years, whether it's price or volume that's the primary driver has varied. Last few years, it's been more price than volume. Why? Because the economy, did a nosedive, and people were seeking less care because they had less money to pay for services. But over time, it's been a combination of both of them. And the element that I want to focus upon today is one of the primary, if not the primary driver of growth in volume, and that's fee-for-service payment. So before I get into describing what are the new payment reform models, I want to give a little focus to, so what is fee-for-service payment and why is it a problem? Okay. I also want to say, as I begin to talk about problems, that I want to be very careful about not pointing fingers. Typically, that's what we do when we talk about our problems with healthcare costs and quality, is to say, well, it's the insurer's fault, or it's the provider's fault, or it's government's fault, or it's employer's fault. What I'm going to describe is just the way the system works. I'm not going to say how we got there. I think actually there's plenty of shared ownership. But I want to describe for you how our system works, because the way that it's structured in a way that produces highly inflationary healthcare costs. That's how it's designed. And unless the design changes, the growth in healthcare costs isn't going to change. So let's look a little bit at fee-for-service medicine. And the other thing is, I also want to invite you to raise your hand and ask me a question. You want to challenge me, that's okay. But I'd like this to be interactive. So please feel comfortable to raise your hand and engage with me at any point. So why is this payment reform and discussion of fee-for-service payment and alternatives relevant to you? Well, first of all, you're paying the bills. And your health plans today, if they're paying fee-for-service, which they are rewarding providers for doing more. Not only for doing more, but for doing more of whatever is most profitable. Okay, so the economic incentive, and again, I'm not speaking about anyone's personal ethics or values, but I'm just saying the economic incentive, if you are paid on a piecework basis, is to do more pieces. And if you can get paid $1,000 for one piece and $10 for another piece, you have an economic incentive to do more of the $1,000 pieces. Okay? And so you're paying the bills when your health plans give rewards to providers for doing more. That's why you should care. Second reason, as Linda said, by and large, employers in recent years in Minnesota have not been at the table when health plans and providers are having conversations about who gets paid how and how much. Okay? And those decisions directly drive your spending. 3, if you don't do anything, the dynamic isn't going to change. There are lots of reasons why there's not a financial or business incentive for there to be fundamental changes in the payment and business relationships between payers and providers. Now, I want to note there have been changes within Minnesota, and I'm going to describe them, but they are not changes that are fundamentally changing the business dynamic right now that fuels volume. And without you at the table, there may not be a strong enough reason for those rules to change. And then I think really, in order to change payment in a way that will remove the incentive for inflation, it has to start with you. And there are plenty of examples of employers who have taken action that has driven changes in the payment and delivery systems. So what's fee-for-service payment? It is the dominant system for healthcare payment in the United States, in Minnesota, and every place else. It's been this way for decades. It's also why that growth curve looked like that. It offers providers a specific amount in return for delivering a specific service to a patient. It is a piecework payment system. The more pieces that you do, the more you get paid. It is inherently inflationary. As long as there's an incentive for doing more, you're going to have more produced. And as I said earlier, you're also going to have more produced of the services that yield the biggest margins. So when you pay for more, you get more. We get lots of volume. The volume sometimes is beneficial, oftentimes it's not. As Linda indicated, there are multiple studies that suggest that 30% of healthcare spending in the United States is pure waste, produces no value to the patient whatsoever. That's a lot of money. So we're getting what we pay for right now. This is the way the system's designed. It's designed to incent more care being delivered, whether that care is beneficial to the patient or not. As I noted earlier, we not only reward volume, but we reward the highest priced services. So services that get paid a lot, cardiology, orthopedics. Right? You see roadside billboards advertising the best orthopedics, the best heart surgery, all across the United States, because these are high margin services. You don't, and I should also note, you also see advertisements for new services. Why? Because usually the new services are priced higher than the old services. And we always believe that the new delivers more value than the old, not necessarily so. We also have financial disincentives. So if we reward some services with high margins, we're not rewarding those with low margins. So you don't as much see billboards saying, we've got the best mental health services. We've got the best primary care services. Why? Because we don't pay a lot for those services. We have shortages of primary care physicians in the United States because we don't pay them a lot. We don't have, to the same extent, shortages of orthopedic surgeons because we do pay them a lot. Again, I'm not saying anybody's a bad guy here, but that's how our market exists right now. The financial incentives are distorted, and it's producing distorted results for you when you are purchasing healthcare benefits for your employees. I'll also note, when we pay fee for service, we only reward providers for doing those services for which they're paid. There are certain things that providers can do that produce benefit, but if they don't get paid for it, by and large, they don't do it, or they don't do it that much. And who's to blame providers for that? Nobody. But patient outreach, hey, you know, you haven't had your mammogram, we want to encourage you to come in, or hey, you're a diabetic and we need to manage your blood sugar and we haven't seen you for months. There's no financial incentive for providers to do that. There's no incentive to coordinate care so that if a patient goes to see a specialist, the primary care physician wants to connect back with the patient and make sure what they get next is what they need. Lots of other services, e-visits, telephonic consultation. There's no payment, so there's no reason to do it. So we also don't reward quality, by and large. So a provider gets paid the same amount for high quality and for low quality. In fact, you actually get rewarded for low quality. Anybody want to guess why? You have to redo it, right? You don't do it well the first time, then the patient's got to come back in, you deliver more services. Okay? So we reward poor quality. There are reasons why hospitals nationally did not focus on preventing readmissions until recently. Linda made reference to hospitals getting dinged for readmissions. Well, it's because Medicare now is financially penalizing hospitals if Medicare beneficiaries are discharged and then get readmitted for a related reason in a short time period. Okay, but prior to that, it'd be pretty hard to convince a hospital CFO that you want to cut down on readmissions, because readmissions is more volume, right? It's more revenue. That's the economic incentive that we've created for providers. So a minute on reference pricing, and I want to mention reference pricing because I know that this is something that a lot of employers talk about. Reference pricing is a benefit design strategy. It's not a payment strategy. And it's a good benefit design strategy because it creates incentives for consumers to seek out care at lower price and hopefully at least equivalent quality providers. But it does not address fee-for-service payment. You're still getting paid fee-for-service, so there's still a volume incentive. So I want to just put in that note about what reference pricing is in this context.